Respected audience, Assalamu alaikum. I am Professor Shamsudjaman, Professor of Pathology. I welcome all in today's 11th lecture on hematology. Today I will discuss about hemorrhagic disorders. Today, day 1 of hemorrhagic disorder. Day 1 hemorrhagic disorder. Today's topic is thrombocytopenia and ITP. Today's topic is thrombocytopenia and ITP, idiopathic thrombocytopenic purpura. Before going to discuss about thrombocytopenia and idiopathic thrombocytopenic purpura, we have to recapitulate about hemorrhagic disorder. First come to hemorrhagic disorder. What we mean about hemorrhagic disorder? I mean, what is the definition of hemorrhagic disorder? Just we want to recapitulate a group of disorder. So, hemorrhagic disorder is a group of disorder characterized by abnormal tendency to bleed. Abnormal tendency to bleed. Why? Due to defect in mechanism of hemostasis. There is defect in hemostatic mechanism. It is called hemorrhagic disorder. Dear audience, if this is blood vessel, this is the wall of blood vessel composed of collagen fiber, elastic fiber. This is the endothelial lining, you know. This is the form elements and blood flows like this, If there is disruption and hemorrhage, if there is disruption and hemorrhage here, this is called hemorrhage. When there is hemorrhage, the blood vessel, platelet and coagulation factors all three plays role, and there is coordinated action of blood vessel, platelet and coagulation factor. So there is hemostasis, and there is stoppage of bleeding, there is hemostasis. So hemostasis mechanism is carried by coordinated action of blood vessel, platelet and coagulation factor. If there is any defect in this one of these three, if there is any defect, either defect in the blood vessel or defect in the platelet or defect or deficiency of coagulation factor, there will be no coordination, there will be no coordinated mechanism, so there will be abnormal tendency to bleed, and this is called hemorrhagic disorder due to defect in either in blood vessel or defect in platelet or deficiency of coagulation factor. And we can classify hemorrhagic disorder into three types of hemorrhagic disorder. One is hemorrhagic disorder due to vascular defect. Another is hemorrhagic disorder due to platelet defect, and another is hemorrhagic disorder due to coagulation factor deficiency. Today come to platelet defect. come to platelet defect. there are two types of platelet defect that are associated with hemorrhagic disorder. Platelet defect two types. One is quantitative defect. One is quantitative defect, that is, in this type of defect the quantity or number of platelet is decreased. It is called thrombocytopenia. It is called thrombocytopenia, that is decreased platelet count. Another is qualitative defect. Qualitative defect of platelet. Here the count of platelet is quite normal, but the quality of platelet is defective. What is the defect in quality? There is functional defect in platelet, and this functional defect in platelet is called thrombasthenia. Thrombasthenia. What is thrombasthenia? The functional defect of platelet. The audience, now come to thrombocytopenia, that is quantitative defect of platelet, that is thrombocytopenia. Today's topic. Thrombocytopenia first, then ITP. The today's topic is thrombocytopenia and ITP. First come to thrombocytopenia. What we mean about thrombocytopenia? Decreased count of platelet below normal is called thrombocytopenia. It's called thrombocytopenia. Now come to normal count of platelet is 1.5 lakh to 3.5 lakh or 4 lakh or 4.5 lakh per cubic millimeter of blood. So the total count of platelet normal 1.5 lakh to 3.5 lakh or 4 lakh or 4.5 lakh per cubic millimeter of blood. If the total count of platelet is less than 1.5 lakh per cubic millimeter of blood, then it is called thrombocytopenia. Now come to what are the types of thrombocytopenia. Types of thrombocytopenia. It may be primary thrombocytopenia. It may be primary thrombocytopenia. It is called ITP. Idiopathic thrombocytopenic purpura is nothing but primary thrombocytopenia. Another is secondary thrombocytopenia. Secondary thrombocytopenia. This secondary thrombocytopenia, is due to certain diseases. Following certain diseases, there is thrombocytopenia, and it is called secondary thrombocytopenia. Now come to first, what are the causes of secondary thrombocytopenia? Now come to causes of secondary thrombocytopenia. I mean, what are the diseases, what are the situations, what are the conditions where there is thrombocytopenia secondarily. Causes of thrombocytopenia secondary. One is drug, as for example anti-cancer drug. Anti-cancer drug. Dear audience, if anybody is treated with anti-cancer drug, what it does, how it causes thrombocytopenia, how anti-cancer drug causes thrombocytopenia. The anti-cancer drug acts upon bone marrow and causes bone marrow depression. It causes bone marrow depression. As bone marrow depression, there will be decreased production of RBC, WBC and platelet. And you know, the decreased RBC leads to anemia, decreased WBC leads to leukopenia, and decreased platelet is known as thrombocytopenia. So anemia, leukopenia and thrombocytopenia, what is the term? It is called pancytopenia. So anti-cancer drug acts upon bone marrow, causes marrow depression, and ultimately it causes pancytopenia. And due to pancytopenia, there is thrombocytopenia secondarily to application of anti-cancer drug. Another cause, aplastic anemia. Aplastic anemia. Dear audience, you know, in aplastic anemia there is hypoplasia of marrow. The marrow material is decreased, and within the marrow the fat is increased. So in aplastic anemia we get pancytopenia. Within the pancytopenia there is thrombocytopenia. Another cause is acute leukemia, like acute myeloblastic leukemia, like acute lymphoblastic leukemia. You know, acute myeloblastic leukemia, in acute lymphoblastic leukemia, patient suffers from thrombocytopenia. Other causes of secondary thrombocytopenia: bone marrow infiltration or marrow replacement or marrow replacement. What are the causes of marrow infiltration or marrow replacement? Dear audience, if this is the medullary cavity and if this is the bone cortical part and this is the marrow, one of the cause of infiltration or marrow replacement is myelofibrosis. Myelofibrosis. Dear audience, if the fibrous tissue or the fibrosis occurs within the marrow, there will be decreased production of RBC, WBC and platelet, and it will lead to thrombocytopenia. If myelofibrosis occurs within the marrow, there will be decreased production of RBC, WBC and platelet, and it will lead to pancytopenia, and that is one of the important features of pancytopenia is thrombocytopenia, and it is secondarily to myelofibrosis. Another is multiple myeloma. Multiple myeloma. Dear audience, you know, multiple myeloma is the cancer of plasma cell that occurs in osseous tissue multifocally. If anybody suffers from multiple myeloma, the medullary cavity is packed up with myeloma cell, that is the cancer cell of plasma cell, that is, it is packed up by the myeloma cell, so there will be pancytopenia, and so there is thrombocytopenia. Another is metastatic tumor. Metastatic tumor of bone. Dear audience, if anybody suffers from metastatic tumor of bone, that is, if any cancer infiltrates or metastasizes in the bone, it will occupy the medullary cavity, and there will be decreased RBC, WBC and platelet production. One is drug, aplastic anemia, acute leukemia, bone marrow infiltration or marrow replacement. Now come to what are other causes of secondary thrombocytopenia. Hypersplenism. Hypersplenism. What are other causes? Some less common causes. Some less common causes of secondary thrombocytopenia. What are those? One is infection, one is liver disease, another is massive blood transfusion. Massive blood transfusion. So if anybody suffers from infection, there is chance of thrombocytopenia. If anybody suffers from liver disease like hepatitis caused by hepatitis C virus, he or she may develop pancytopenia or may develop thrombocytopenia and massive blood transfusion. So these are the causes of secondary thrombocytopenia. Now come to ITP. Dear audience, now come to ITP. It is called idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura. What are other names of idiopathic thrombocytopenic purpura? Other names. Other names of ITP. It is called primary thrombocytopenic purpura, it is called primary thrombocytopenic purpura, and it is also called, or it is called, essential thrombocytopenic purpura. Another is purpura hemorrhagica. Purpura hemorrhagica, and another name is autoimmune thrombocytopenic purpura. Thrombocytopenic purpura. Dear audience, you know in ITP there is production of antibody against thrombocyte, and this antibody is autoantibody, so it is called autoimmune thrombocytopenic purpura. Dear audience, if anybody suffers from ITP, if anybody suffers from essential thrombocytopenic purpura, if anybody suffers from primary thrombocytopenic purpura, or from purpura hemorrhagica, or from autoimmune thrombocytopenic purpura, what may be the clinical presentations of that patient? Now come to presentations of ITP. Dear audience, in ITP you know there is decreased platelet count, there is thrombocytopenia. So what may be the presentations? Presentation is purpuric spot. Patient may come to you with purpuric spot. Patient may come to you with hemorrhagic manifestations. Hemorrhagic manifestations. like hemorrhagic manifestations like gum bleeding, nasal bleeding, it is called epistaxis, parrectal bleeding, patient may come to you with hematuria, patient may come to you with menorrhagia. So these are the different presentations of patient suffering from ITP. So if anybody suffers from ITP and if you suspect clinically it could be a case of ITP, how can you diagnose in laboratory? Now come to laboratory diagnosis of ITP. Laboratory diagnosis of ITP. First we have to do blood examination. Bone marrow examination, detection of antiplatelet antibody, detection of antiplatelet antibody. So blood examination, bone marrow examination and detection of antiplatelet antibody. First come to blood examination. Dear audience, you know ITP, there is decreased platelet count, so there is hemorrhagic manifestations. In blood, first we have to do bleeding time. As it is a case of thrombocytopenia, decreased platelet count, so bleeding time is prolonged. Bleeding time will be prolonged. Then coagulation time or clotting time. The clotting time or coagulation time will be normal. Then we have to do hemoglobin. It will be reduced. That is, patient is anemic. Then we have to do ESR. It will be elevated. Then we have to do tourniquet test. It will be positive. Then we have to do peripheral blood film. You know, in peripheral blood film we search for RBC, WBC and platelet. First come to RBC series. The cells of RBC series show hypochromia and microcytosis. That is, cells of RBC cells are microcytic and hypochromic. Then WBC series, cells are mature. And show normal count or leukocytosis. Dear audience, at the time or during the episode of hemorrhage, there will be leukocytosis. Platelet decreased in number. Platelets in decreased in number in the film examined. So, the informations in peripheral blood film, cells are microcytic and hypochromic RBC series, cells are mature and show normal count or leukocytosis WBC series, platelet decreased in number. Sometimes a small and large atypical platelet may be found. Sometimes a small and large atypical platelet found. Dear audience, we have to do total leukocyte count also. The total leukocyte count may be normal or show leukocytosis. When leukocytosis during the episode of hemorrhage, there will be leukocytosis. We can recall hemorrhage is one of the cause of leukocytosis. So, during the episode of hemorrhage, total count of blood will be increased, that is leukocytosis. Then differential leukocyte count, it may be normal distribution or during the episode of hemorrhage there will be neutrophil predominance When predominance? During the episode of hemorrhage. Otherwise, differential count is within normal distributions. Now come to bone marrow examination. Dear audience, we know in bone marrow we see the cellularity, we see the erythropoiesis, granulopoiesis, myeloid erythroid ratio, platelet, etc. Now come to bone marrow findings of ITP, that is idiopathic thrombocytopenic purpura. Marrow is hypercellular. With increased myeloid erythroid ratio. So, marrow is hypercellular with increased myeloid erythroid ratio. Erythropoiesis is active and normoblastic. Granulopoiesis is active with all stages of maturation. So, marrow is hypercellular with increased myeloid erythroid ratio. Erythropoiesis is active and normoblastic. Granulopoiesis is active with all stages of maturation. So, it is not a disease of RBC, not a disease of WBC. What about the megakaryocytes? Megakaryocytes seen adequate or increased in number. So, in the bone marrow we will see adequate number megakaryocytes or the number of megakaryocytes increased than normal. No parasite found. In the marrow examined. Dear audience, it is not a disease of RBC, not a disease of WBC. So we'll get the erythropoiesis active and normoblastic, and get granulopoiesis active with all estrogen maturation. But there is normal or adequate or increased in number of megakaryocytes in bone marrow. Dear audience, there is a question for the learners, there is a question for the students. If this is blood and if this is bone marrow, if this is bone marrow, suppose this is the bone marrow, medullary cavity, and this is the bone marrow. Here we are getting adequate number of megakaryocytes or increased number of megakaryocytes. This is megakaryocytes. The number of megakaryocytes is adequate or increased than normal within the marrow. You know, from the megakaryocytes platelets are formed. By the budding process, platelets are forming. So platelet is coming in the blood. The platelets are forming by the budding process from the megakaryocytes of the bone marrow, and platelets are coming in the blood. But why we get thrombocytopenia when we count the platelet in blood? Why thrombocytopenia? I recall the question: adequate number of megakaryocytes in the bone marrow that are producing by budding process platelets. Still then, why there is platelets is decreased in blood instead of adequate number of megakaryocytes in the bone marrow? Answer is that as there is formation of anti-platelet antibody. As there is formation of anti-platelet antibody, the platelet that is forming from the megakaryocyte is coming in the blood from the bone. Just at this point, the antibody catches the platelet. As the antibody catches the platelet is destroyed here. So although there is sufficient number of megakaryocytes in the bone marrow, although there is production of platelet by budding process from the megakaryocytes, the produced megakaryocytes are destroyed by the anti-platelet antibody. So although there is adequate number of megakaryocytes in the bone marrow, there is thrombocytopenia in blood. Last one, detection of anti-platelet antibody. And detection of anti-platelet antibody in blood is the diagnostic tool of ITP. Again, detection of anti-platelet antibody in blood is the diagnostic tool of ITP. Dear students, there is another question: why it is called ITP? Why it is called idiopathic? The answer is like this: the cause of such type of thrombocytopenia is not known, so it is called ITP. But we know there is production of anti-platelet antibody, and this anti-platelet antibody is associated with the thrombocytopenia. So now the cause is known. What is the cause? Production of anti-platelet antibody is the cause of ITP. Still then, why it is called idiopathic? Still then, it is called idiopathic because why anti-platelet antibody is formed, it is not clear. Why anti-platelet antibody is formed, it is not clear. So still then it is called ITP. This is all about ITP and thrombocytopenia. Today up to this, thanks all.